is a death sentence, please complete your diagnostic test. Your diagnostic test will absolutely tell you whether you will pass or not with a high level of confidence. So when you take your diagnostic test, you should aim for 80% or better on each one of the 4 diagnostic tests. You should start doing those diagnostic tests 10 days before the board. And then you take one, and then you check the answer. You look over your PDF, take a day in between, and go for the next test. So that way you can finish all 4 tests before your ANCC exam, right? Or AANP, it doesn't matter. The course works for both. Doesn't matter what test you're taking. Just as I open my email today, Deborah, she passed the ANCC and she passed the AANP, right? So as long as you're studying and understanding the content, it does not matter which test you take. Now we follow precisely the ANC blueprint, right? We look at the blueprint and then we say, okay, look, they're saying this is going to be on the test. So we kind of like look at this blueprint. Let me share with you guys. So if you are new and you have never seen the blueprint, you'll be like, how do we come up so close to what's going to be on the board? Well, it is actually very simple because they tell us on the blueprint. I'm going to open here and I want to share with you a little bit. And then we're going to see what is going to be on the test from module 1. Okay, so let me stop sharing here just for a second and let's look at the blueprint. So, oh, where is it? Why is it not sharing? OMG. Are you guys seeing the blueprint? No, right?
No.
No.
No, right? Okay. 1 second. Because I just had a... All right. All right. So now I'm able to share the blueprint. But look what the ANCC is now. Well, first thing is 107 questions from modules 1, 2, and 3. What is the most important module? It's domain 2 because it's 41 questions. So what else can we say from here? We can say that psychotherapy, it is the least important, 25 questions. And number 5, it is the easy hanging fruit because once we learn the ins and out of that, we can get those 26 points pretty easy. So in summary, if we really know modules 1, 2, 3 really well, we already made enough to pass because we only need 105 questions, right? Questions that count, obviously. And there will be 33 with 33 plus 41, 107 questions. Now let's take a look on what's going to be on module 1 per the blueprint. Well, advanced psychophysiology, contraindications, interaction, and adverse effects. Have you guys noticed they do not look for the common thing on medication? They look for things that are cause agranulocytosis, aplastic anemia, liver toxicity, pancreatitis. So basically, they're telling us what they're going to test on psychopharmacology. That is the reason why you do not need to know psychopharmacology in depth. You need to know what is in the course. How about we talked about pharmacokinetics, EPS, NMS. All this is in a course. Neurodevelopment, neuroanatomy, your brain. How about neurophysiology? It is your neurotransmitters, right? And genes interaction, things like some conditions that are can be passed on from the offsprings and things like that. Physical assessment, things that we would look for, and then we start on module 2. So it is very important that you make it time to once you cover the PDF, once you have gone through the content, you make time to go back to the PDF. So that way the information is super fresh. Okay. All right. So this time it's about to get started. So good luck, everyone. So let me explain one more time. Once you are in a game, you see your name in the screen right now. Okay. How you play it is very simple. 4 boxes will show up, and you will use your phone to enter your answers. You only have 1 minute per question, and then after that we can talk about it. Once I start, I cannot stop the game. So just wait until it is the break time, and then we can talk about any of your concerns. Good luck, everyone. Let's get started. I hope you make the podium today. All right, 25 seconds left. Yes, so we're talking about, what are we talking about as far as what is the condition, right? Are we talking about schizophrenia? So those folks, they all answered correctly. The first one, the Rosaline, she was the fastest. That's why she probably got more points. When we talked about serotonin and norepinephrine, right? So it is really about mood regulation here, right? Things like bipolar. Now, be careful. Sometimes we'll put in a corner and say, what is the neurotransmitter for X, Y, and Z? Well, the true answer is a lot more complex than that. It's not only serotonin or norepinephrine, right? It is glutamate, increasing glutamate. It is a decreasing GABA, but serotonin and norepinephrine are the two most important for mood dysregulation, specifically bipolar. Now, when you are answering any mood question, right, like bipolar question or DMDD or uh, not DMDD, but when you a child that having mood liability, you want to give a mood questionnaire. Write that down. A mood questionnaire. It is very important. Okay. How do I select my answer? You use your phone if you are logged in. Okay, on your phone. All right, so make sure you give it a mood questionnaire. If you're asking what should you do first, you want to give a mood questionnaire because you are assessing, or the patient's telling you things about their mood. Okay. All right, next question. So before we get started, let me just say, if you're starting now, you can go to www.kahoot.it. The pin code is 303878, and then select a nickname, and you should be able to still join the game. I put this in the chat box. Next question. All right, we got 90 answers, and we got 30 seconds left. All right, so I don't think we need explanation. Everybody really got it correct. If you see coarse hand tremors, that is toxicity. If you see fine hand tremors, then it's more likely to be a side effect. Just know that fine hand tremors, you really can't see. The patient may tell you, but if you can see the hands kind of moving away, it's coarse hand tremors. That is high yield for the test. Is something that they always ask for. Another question that people often ask is, can lithium cause hypothyroidism? Yes, it can. Now, can you give it a medication? Yes, you can. Uh, you can give a medication. Okay, so as long as if it was caused it, you can still correct it and give it a medication. If the prescription that you give cause the symptoms, you can correct. In real life now, it's more likely that you collaborate, or if there is an answer to collaborate, you can still collaborate, but can you actually do it? Yes, you can. Okay. All right. Next question. All right. Somebody muted the music. I'm not sure why, but oh, here we go. Back on with music. All right. 5 seconds. Pick your best answer and go. All right. So again, I can see you guys really remember scientific foundation. So everybody said, hey, or lithium, right? For the test, always stop lithium before you order lithium, right? If you see signs of lithium toxicity. Here, it wasn't given an option to um, stop lithium. The best option was to order check lithium levels is the first step. Okay. Um, Collaborate with the dietitian to develop a personalized nutrition plan. Okay, so any questions? So in psychiatry in general, it doesn't really matter as much. In psychiatry in general, it is very hard to stabilize your patient. If there is a way to compensate for that without changing a stable patient, do that. So in questions in which the antipsychotic is working, you do not want to switch to a skinnier antipsychotics like Abilify, Latuda, Acenopine, or Geodon, right? Not at first. What can you do first? lifestyle modification. Okay, so lifestyle modification, it is high yield because it really touch base on, hey, I noticed that it is working, everything is going well, but you have gained some weight. Is that something that we can do together to still be on the medication and reap the benefits from it? If we can compensate for more exercise, better diet control. That is the first thing you do in psychiatry, right? For example, a medication that gives a lot of insomnia, it is Prozac. Why? Because the longer half-life. Patients often will say things like, it is working, I feel calmer, I don't feel depressed, but I'm up until 2 a.m. And then the first question I ask is, what time do you take your Prozac? Oftentimes they will say in the afternoon, or things like, I usually take at night when I go to sleep, right? So that is probably one of the reasons why they are having insomnia. If that doesn't help, then you can add something else to it. But try to do some modification before you change the medication. Now, in the cases of antipsychotics, things like other antipsychotics like Abilify, like Geodon or Latuda, these would be a very good options if lifestyle modification failed. In terms of mood stabilizer, Lamictal would be the called skinny mood stabilizer. Be on a watch out for answers, whether it's antipsychotics or mood stabilizer, and picking the correct answer. All right, on the test, anything that is persistent, constant, always there, is most likely a toxicity level, all right? Even though it didn't say coarse hand tremors, said persistent, right? Uh, Leukocytosis, elevated white blood counts, it is expected to some degree, right? But we're more concerned about of the persistent hand tremors, right? It really shouldn't be persistent. It really, you know, you could expect as a side effect is fine hand tremors, but if something is persistent continuously, and you can pick up on that for the test as a possible toxicity. It doesn't even matter what medication we're talking about. Anytime you hear consistent, always, or explosive diarrhea, projectile vomiting, that should never be considered a side effect. We're more likely than not looking at toxicity level for whatever medication we are looking at. Okay. All right, you guys are very fast. got 96 answers. 15 seconds left. All right, no secret, right? The board loves lithium and NSAIDs together. So it may not say NSAID, they may say ibuprofen. It may say other categories of NSAIDs. So be on the watch out for that because it reduces renal clearance. What else should you watch out for? Lithium and thiazide, lithium and ARBs or ACE inhibitors. Really, any medication that are kind of competes for excretion through the kidney could have a possible effect on decreasing renal clearance, right? Competing to leave the body. But most likely, NSAIDs, thiazides, ACE inhibitors, ARBs. What else about ACE inhibitors? You need to know that ACE inhibitors is a class of medication. Well, it is a class of medications. They are often prescribed for those with heart failures. Okay, why is that important? Well, for the simple fact that in psychiatry, we have to understand a little bit more than what we are prescribing, so that way we can rule out a medical cause rather than saying straight up this is a psychiatric condition. Okay. All right, I can stop taking lithium if I feel better. No, there is a need for more education. No surprise for the board. Teaching for lithium is high yield, right? So what are the most important teaching regarding lithium? Always has to do with sodium, right? If the patient is hyponatremia, lithium will increase. Dehydration. So let's take a second here. What are the population that would be at risk? Soccer players, construction workers, right? Building homes in a hot sun in Miami, for example, right? They would be at risk. People that are going camping, there would be a risk. So what kind of teaching would you tell someone going on camping? Please make sure you take 2 liters of water with you if you're going on a hiking or camping trip, right? So you understand that lithium and dehydration don't go together. So the board is likely to ask you, how would you explain that to a patient, as I mentioned, okay? It's always the application. We provide you the knowledge. And if you fully understand, when you see questions about teaching, you'll be like, yeah, I remember. All right, we just covered that, I guess. Should get 100%, hopefully. close to 100%. I should limit my water intake to avoid diluting the lithium. That would be a mistake, right? They should have plenty of water. Obviously, anything in excess, too much of it, would be not ideal. But it's a lot worse if they are dehydrated, okay? So staying hydrated, it is something that the board is looking for. Patient understands that. Why is it so important about lithium and dehydration or lithium and hyponatremia? Because the lithium has something called narrow therapeutic window, right? 0.6 to 1.2. When it reaches 1.5 and over, we have to stop lithium. Now, that brings the most important point about this. If the patient is manic right now, comes to your office, manic, right? Will you start lithium or a antipsychotic? You start the antipsychotic, even though lithium is the go-to medication. But why then? Well, because you do not want to overshoot, right? Remember, narrow therapeutic window is dangerous. If you give too much lithium, it takes a while to stabilize it. So if you give too much lithium too fast, you could immediately, the patient could go immediately in toxicity. So in practice, what we do is we give an antipsychotic like olanzapine, maybe admit the patient. Once the patient is stable, then we transition to lithium. Okay, very important, very likely to be on your board, because that is beyond just reading the book and be like, yeah, lithium is neuroprotective medication choice. Okay, lithium is the #1 medication for mania, but don't forget about the details and the reason why you would pick an antipsychotic as the first medication, then transition if you need it. Okay. All right, we have 10 seconds left. 3, 2, 1. Yes, lithium improves cognition and reduce decline in bipolar patient. Well, it is well known that lithium is neuroprotective medication of a choice for bipolar patient. Also, is the only medication that has been shown to reduce suicidality in bipolar patient. The only medication that has been shown to reduce suicidality in schizophrenia patient is Clozapine. These are two important facts that you need to understand for the board. Only two medications that has shown to decrease suicidality. Then you got to look for who you're giving to. What's the diagnosis? If it's if it's bipolar, lithium is the answer. If the patient is schizophrenic, then Clozapine would be the answer. All right. Yeah. So why not the blue, right? Well, you can give a antihypertensive, and you should, but if you don't take it away, the reason why they are having this hypertensive crisis, then is a mute point, right? You want to stop what's causing the problem and then give it a antihypertensive medication. In fact, at that point, the patient is going to be to the ICU, right? Because they need to be monitored closely, and most likely they will need IV medication to drop the blood pressure.
Dr. Lopez, I have a question,
Sure.
please. Sorry to take
Yes.
you back. Why did you say you would give a patient an antipsychotic as opposed to lithium for mania?
Because lithium has a neurotherapeutic window, and you cannot give lithium fast.
Okay, but what was the backstory that you gave?
Well, if if someone comes to your office and you're in manic stage, you are not going to keep the patient for a couple weeks until lithium is under control, right? Because the lithium, you will be checking the blood almost in a daily basis to make sure that you're not overshooting. So how can you get mania under control? Start with a antipsychotic. Once the patient is somewhat controlled, then you switch to a lithium.
Okay, thank you so much.
Yes, very important. Okay, very, very important. Now, something else that's very important, very confusing for a lot of people, right? When you are giving MAOIs, the enzymes that eats and degrade the MAOIs, right? They kind of die off. So you want them to regenerate, regenerate, not degenerate. Okay? Because if they degenerate, now they will have excess of MAOIs. That is so important. You want the enzyme to regenerate. And I am exaggerating here because it is super important. I would know this for the board. Okay? All right, so very important. Glad that some of you guys got it wrong. It is important that we can get it wrong when we're practicing so that we don't get it wrong on the test. So start with NMS. What causes NMS for the board? We're going to keep it simple. If you hear NMS, first thing you say is antipsychotic. Nothing else for the board. Okay, there are other things that could cause, but there are much less to be tested or much less to occur. So from now on, anytime you hear NMS, you think antipsychotic. Okay, so if you do that, you take it away the confusion with serotonin syndrome, because what causes serotonin syndrome? Serotonergic medications. Now, the blue, it is a classic confusion, right? It's talking about Depakote, and I mix it with lithium just to get those folks that might not be sure what is Depakote toxicity. You have to know what are the FDA warnings for Depakote. Anybody remembers the two FDA warnings for Depakote?
Yes,
Pancreatitis,
hypertension,
hepatitis.
toxicity, and pancreatitis and
Yes, pancreatitis and liver toxicity, right? But there is this side effect that's well known to be with Depakote, which is ammonia level, right? So here it's talking about ammonia level. Okay, so the last piece here is continuing monitor for EPS. This has nothing to do with EPS. EPS is from antipsychotics. Okay, so it's very important that we know if we looked at the blueprint, is looking for contraindication, weird side effects. So what do we need to know for the board? All FDA warnings. And if it is important, it is in your PDF. Okay, so yeah, in this case here, we're really talking about elevated ammonia levels. So what I really need you to remember is liver toxicity and pancreatitis for valproic acid, along with order your LFTs and ammonia levels. You also need to know what is the normal level for valproic acid. Otherwise, how would you know when you're in toxicity levels? We'll cover that during the weekend event. We'll cover all these details that you must know. Where would you find the PDF? In the crash course review. We have 4 PDFs. You cannot skip that, and you cannot go over on the last week that you are testing. You need to have some time because a lot of content put together in the last week. Okay, so but if you know those PDFs, I can guarantee you, you are likely to pass the board. Okay. All right, so if you know pancreatitis and liver toxicity, then you need to know how the patient presents, right? So in this case, we have a liver toxicity. Yes, they will present with the upper right quadrant. They may have yellowish pallor of the skin, right? Because that is hypotoxicity signs and symptoms. So what we need to do is obviously discontinue the medication and then get LFTs, right? Just to ensure uh, it is exactly what we are thinking. All right, we got 10 seconds left. All right, so off, great. So again, what's weird about carbamazepine, right? We need to be watch out for agranulocytosis, aplastic anemia, and Asian population, because in the Asian population we could have Steven Johnson syndrome, right? So we need to get the right task before we prescribe to the Asian population. For the board, if the patient is on carbamazepine or clozaril and they sneeze, being dramatic here, right? If they have a sore throat, very likely to be board scenario. A mild fever, I don't care what the ANC is, right? It can be 2,000, 2,500. If they have any signs of infection, you stop the medication. And questions like that, they are most likely to present a patient that's doing super well. They'll shoot the ANC level because everybody knows ANC less than 1,000, you stop the medication. So how boards love to do it is saying, patient's doing well, uh, WBC is 5,000, ANC is 2,000, otherwise feeling okay, but temperature, give you vital signs, and just makes give you a temperature of 100.05, right? Not 105, 100.05, and just say nothing else and say, what should you do? Well, they're trying to kill you in that the patient has a mildly elevated fever, and that could be an indication of the start of infection. Sore throat would be a good one, or just malaise, feeling tired. These all could be signs of infection. In that case, we need to stop the medication immediately. Okay. All right, we got 30 seconds left. All right. Yes. In order to assess how the how the kidney is doing, right? We don't have like a direct, sure way, but indirectly we can look at BUN and creatinine. So when we look at BUN, think of a child to adolescent, 10 to 20, and creatinine is great because it's the same level as lithium, 0.6 to 1.2. So that works well for us. So that means if the BUN and creatinine is elevated, they may be dehydrated, they may have a hypofunction kidney condition going on. Maybe it's acute kidney distress, right? Or insult. So be on a watch out for that. Now, boards love uh, increase in protein levels in the urine. It is concerning, yes, but it is not a reason to stop lithium. In that case, if there is nothing else showing as signs of infection, you continue lithium and you continue to closely monitor the patient. If you have a protein of 3 plus, 4 plus, right? It's just saying, hey, it is a warning sign, but it's not necessarily a must stop lithium. Okay, we'll continue to monitor. If they don't have any other signs and symptoms of lithium toxicity, then continue to give the medication. If they do, then stop lithium. All right, so BUN 10 to 20. So this is normal. YBC 4 to 11, 4,000 to 11,000. 7,000 is normal. TSH 0.5 to 5 within normal limits. The only thing that's related to kidneys is BUN and creatinine. BUN within normal limits, so therefore we have one choice left, creatinine, right? 1.5 is above the 1.2 level. Just remember, creatinine, same levels as lithium, 0.6 to 1.2. 1.4 is just slightly above normal levels, which could be an indication of less than optimum renal perfusion or injury possible, right? Excellent. So the two medications that can cause a decrease or life-threatening infections is Clozaril and Carbamazepine, right? Because of a granulocytosis there. Now, two medications that can cause most weight gains, olanzapine and Clozaril. Very important that you know how to monitor Clozaril, right? I like to call it the 6, 6, and 6 rules. For the first 6 months, weekly. So every week, every Monday, you collect lab. For the second 6 months, we're going to do bi-weekly. And for the remaining of the time, monthly. So initially, for the 6 months, weekly. For the next 6 months, bi-weekly. And then after that, it's going to be monthly, okay? So please know how to monitor or collect labs for Clozaril. It's very important. Yeah, all the other three colors, right? Severe restriction food intake, that would be anorexia. Engage in excessive exercise, most likely anorexia. And fear of gaining weight, most likely anorexia. In fact, bulimia, they have normal or slightly above normal BMI. Okay. Few things about bulimia. They may have something called Russell signs, where they purge, and they may have a callous knuckles, right? The tooth may be decayed. Few things for anorexia. BMI drops below 16. It is reason for admission. Well, what if it's 14? It's an immediate admission. What else about anorexia? Watch out for refeeding syndrome, right? Think of someone that has been not eating for a very long time. They get the big plate and say, well, now I'm going to start eating, right? They may have this influx of electrolytes that could be dangerous, right? So be on a watch out on teaching and when to admit patients with anorexia. Very important. Right. The question was a bit confusing, right? Is he trying to, is he still smoking or not? Right. So watch out for questions with olanzapine, Clozaril, and Seroquel, most likely, more likely than risperidone. But yeah, smoking, it does induce or speed up the breakdown of the 450 enzymes, right? If it speed ups, less of it is available. So therefore, we could be risking subtherapeutic levels, right? Now, if the patient stopped smoking, then you would need to be watching out for too much of the medication, possibly causing toxicity level. Therefore, the board doesn't get none of this. The board is going to ask you, what will you do? If the patient stops smoking, you decrease the dose. If the patient starts smoking, then you increase the dose. So you learn the basics and what matters your action, or how are you going to apply this information to your patient. All right. So both of these medications are well known and well to be tested to be inhibitors, depending what the other substrate. But most importantly, they are both well known to cause discontinuation syndrome if they stop the medication. If the patient stopped the medication abruptly, okay. But now, guess what? They are also well known to cause serotonin. Um, if they are combined, serotonin syndrome, right? So two different things: serotonin syndrome, or if they stopped abruptly, serotonin discontinuation syndrome. Okay. Yeah, right. Cerebellum is all about your balance and coordination, right? Think of how alcohol affects the cerebellum, right? Uh, If one had too much to drink, they may not be able to walk a line straight line, right? So it definitely affects coordination, balance. For example, if they close their eyes and put the hands forward and you give a little push, they will be likely to fall when someone else will be able to control their balance. Okay. All right, we got 5 seconds. Pick your best answer. 3, 2, and go. Yes, temporal lobe, right? A parietal lobe is all about your sensories, right? So, uh, inability to speak would be the frontal lobe, right? Now, inability of understanding would be your temporal lobe, receptive speech, right? Comprehension, being able to comprehend what is said. Um, Very important, right? Who controls the circadian rhythm? Very important. Circadian rhythm. Temperature. Yes, absolutely. The hypothalamus, remember circadian rhythm. Okay, very, very important. Appetite, hunger, hormones, body temperature, that is all the hypothalamus. All right. Okay. So you need to know second generation or atypical, what we added to it, the 5H2A antagonism, right? Receptor. So that is the magic for the atypical or second generation antipsychotics. So on the board, sometimes they may not say atypical. They may not say first generation. What they might say is D2 antagonistic. In that case, you know they're talking about antipsychotics. Okay. So atypical, they added the 5H2A. Now, depending of which dopamine pathway, it releases more dopamine and therefore causing less of a problem, whether it's nigrous striatal with more dopamine, less acetylcholine, therefore you have less EPS. The tubular fundibular pathway, because now you have more dopamine, you have less prolactin, therefore you have less osteoporosis, amenorrhea, galactorrhea, increasing breast size. And in the mesocortical pathway, because you have more dopamine, now you have less symptoms of the negative side effect. And it still does the job on the mesolimbic pathway, which is responsible for the positive symptoms of schizophrenia. Okay. Very important question. Okay. Okay. So what's important? Few things. For Lewy body or Parkinsonism, do not give antipsychotics, right? It will likely worsen the condition. Now, how can you treat EPS is by giving a anticholinergic medication, because the problem is too much acetylcholine. So you give something to curb the acetylcholine by giving a anticholinergic. If the patient has akathisia, give it a beta blocker. Okay? If the patient has TD, do not give a anticholinergic. Give a VMAT2 inhibitor, also known as Austedo or Ingressa. That is also highly tested content. All right. So the reason why I spoke about akathisia is because I knew the next question would be about akathisia. And in a way, I was hoping that you guys really pay attention to what I mentioned. That akathisia, you give a beta blocker. What is akathisia? Restless, right? So for akathisia, the number one medication would be propranolol. If propranolol is not there, then cogentin could be considered, but the best answer is propranolol. Okay, for akathisia. Akinesia, then cogentin. Akathisia, propranolol. If you increase the dose of antipsychotics, you're going to cause it more akathisia. Akathisia, right? So for that, you really want to consider propranolol. Very important question here. Very important. Then do not give, if the patient is asthmatic, do not give propranolol at all. Very important question. All right. So what I wanted to call attention here, this is a very important question. Reglan can cause TD. Okay. Reglan can cause TD. And so is tramadol. Reglan and tramadol can cause TD. Well, what if the patient is on Risperdal and later was added Reglan? Now you have double the chance of initiation of TD. So on the test, for any antipsychotics that the patient develop EPS symptoms early, they are more likely then other patients should develop TD and Parkinsonian earlier than other patients. So that is important information, because knowing that, you can start to pre-game on what to do. Okay. Remember the AIMS, the scale for TD. Okay. High potency antipsychotic. What condition should I be concerned? All right, so we talked about NMS equals to antipsychotics, right? Quote unquote here, not being super precise. But for the board, you look at what is the patient taking? Serotonin, then it would be serotonin syndrome. What is the patient taking? Antipsychotic, then we would be looking at NMS, neuroleptic malignant syndrome, to help you guys to discern that. And don't forget the medications for one or the other, right? Bromocriptine, dantrolene, NMS, cryptoheptadine, serotonin syndrome. The board love to mix and match just to get those that kind of know the content, but really don't know the content in depth.
Oh shit! What did I do?
All right. So, oops, 1 second here, folks. Let me just close this up. I was looking for something to share with you. All right. So, anytime you have a stable patient and they become unstable, right? You have to wonder what happened, what was added to the equation. I was looking at this PDF here right now to share with you for a second, because I think this is such a easy point that a lot of students are missing, right? And we said, hey, you really need to know either inhibitors and inducers, and then you need to know medications that can cause mania, right? So for example, here on our PDF, we mentioned um, medications that can cause mania. How are we going to remember those? This is often get people confused, because now they can say this medication was an inhibitor of this or inducer of that, and you have no idea. Well, if you memorize four celled, the four S's, what's the first S? Syphilis, Second S, SAMe, steroid. The board will never say steroid precisely. They will say something like dextromethasone or say an inhaler of any kind. Oh, what's the fourth S? St. John Wort. All these four S's for four-celled can cause mania. How about A is for your antidepressant, I, azonoside, LE, levothyroxine, right? Well, wait a minute. Levothyroxine is given to patients that have hypothyroid, but it could shoot too much and becomes excessive uh, thyroid, right? The D, disulfiram. So if you memorize four-celled, and then you memorize the medication that can cause depression, which is ASAP, ABBs, right? So let's go ahead. ASAP, ABB. So what's the ASAP? Antiviral. The S is steroid. A, Accutane. And P is progesterone. AB is for any antineoplastic medication. B, beta blocker, can cause depression. And the B's is benzodiazepine, interferon, and statin. Now you have everything you need within reasons to understand when you have two types of medications being combined, you can almost, with some degree of certainty, right? Because there's too many medications, say, is this an inhibitor or is it an inducer? Okay, how about none of that? It could be that the medication causes mania or depression. That is the reason why my patient is unstable. So now the next piece of the puzzle is, what do I do? Right? That is what the board cares. When you have a patient stable, and then you know what destabilizes the patient, you can say two things. One, most likely, is increase the medication that you have control. What do you have control here? You have control your psychotropic drugs, in this case, olanzapine, or collaborate with your PCM to decrease the steroid. Okay, so I would write it down, my acronyms for inhibitors and inducers, as soon as I sit down for the test. And I would write it down, those two acronyms, ASAP, ABBs, or four-celled, because I can easily look at it and remember what the four-celled stand for as soon as I see the medication on the test, right? Is one way of doing it. There are several ways of doing it, but I really think knowing those medications that can cause mania or depression would yield few extra points for you. Remember, we had one of our students that did not pass the board, and I am not proud of that, and I do not hide that because of one question. One question. That is right. That is cannot even say it, right? Because it is like one question, one extra hour of doing something or trying something different could get the person the extra question, and now the person does not need to wait 2 months. So stay highly engaged on the material so that that doesn't happen to you. Okay, so it's always a warning signs. Every time we learn something new, it's always good to share, and maybe you'll prevent one person from not falling into the same path. Again, the board will never say steroid. What they'll say, prednisone. So what does it mean? Well, you need to know that anything that ends in ONE, it is a steroid. So that is easy now. If I know ONE, I can almost count this is a steroid in disguise. All right. So what caused the problem? Antipsychotics. What is the condition that I should be looking for? NMS. How do I treat NMS? The board love to mix and match. Neuroleptic malignant syndrome gives cyproheptadine? No, because cyproheptadine is for serotonin syndrome. So if you don't know it, it's not even about this subject. It is a proof that they will trick you, right? So please, as you walk in the test center, go there like Jesus sent you. Because if he already walked away, man, you got this. But you have to do your part. You have to feel confident that that you know your skills, that you have gone through the many tests that we give you, the question bank, and walk in the test center confident because you will pass. Don't kind of know this stuff because there is many ways to trick a student that kind of know the content, right? So what is delirium? That's exactly what the question is asking you. All right, we got 20 seconds. All right. Yes. So basically, delirium, what do I really care about delirium? One, high mortality rate. Okay. Two, the definition. It is a change in mentation, levels of conscious. And three, do not give benzodiazepine unless the delirium is caused by alcohol withdrawal. That would be the only instance in which you would give a benzodiazepine. You do not want to make that patient more confused, right? So let's see who made it the podium today. Guys, if you didn't, Travis, well done. Princess, okay. And Natalie, well done, guys. You did really good. Third place, we have Mrs. Love, fourth place, fifth place. But all of you guys are really the rock star, right? Especially if you didn't make the podium, especially if you learned something, because we want you to make mistakes now so that you don't make the mistake on the test. So it is a good thing to make a mistake. If you felt this was helpful, now you know what to watch out for, right? Let's be proactive and get those things taken care of before the test date. We are holding the Super Crash Course Review. Make sure you get some chocolate, lots of coffee, lots of water. 2 days intense. Do not skip your diagnostic test. We have 4 of them. So it's your chance of getting the things that you kind of know square away, really good, so that when you walk in a test center, is for one reason, to pick up your board certification. Amy, you have a quick question there? Then we're going to show you where, just quick here, going to show you where in your course you'll find the documents. Any other question about the course we can answer here as well. So now is a free time to ask any questions at all. Amy, go ahead and please ask your question first.
Okay. Hi. I haven't finished all the modules. I'm halfway through module 3. So should I shift over and just do the diagnostic tests in preparation for this weekend, or finish the modules?
No, I think, Amy, you are testing soon. Is that right?
February 20th.
Okay, so okay, not as soon as I thought. No, Amy, you do not. You do not want to do your diagnostic test, and the reason why you do not want to do your diagnostic test is you want to take it as if.
Okay. So go ahead and keep on with the modules and come this weekend, for that, but then wait until I get closer to my actual test date to take the diagnostics. Oh, what happened? Where'd he go?
You ready to fell off.
Hey, I'm glad you asked that question because that's where I'm like, I just started. I'm like, am I even in the right Kahoot?
Oh, yeah. It's just module 1 and module 3 are like the longest.
Mm-hmm.
And I haven't gotten all the way through them. And so I was confused on whether or not I do them because this weekend's the crash course. And so I'm glad I asked because
Yeah.
I wasn't going to ask.
Yeah, no, it's if you don't ask, you might do things that you thought would be probably a good idea. You want to save those about 10 days to 2 weeks before your test date. You want to do them like they are your board. The same experience is timed, at least for the first 2, but give it 14 days before the board. So ideally, you have a board date, let's say it's the 15th. By the 1st should be your board date, right? And that's when you're like, okay, I'm ready for the board on the 1st. And then those 14 days or 2 weeks left, you kind of just adjusting for any last minute things that you may want to learn or kind of rehash the content that you already learned.
Thank you.
Okay, my pleasure. Next person is Mrs. Campbell.
Hi, Professor. How are you?
Good. And yourself?
I'm good. I have 2 questions for you. So when I was watching your crash course in the, in your modules, you had shared your screen at one point when you were doing the questions. And on the screen, it showed like each of the modules had blocks of questions. Module 1, module 2, 3, 4, and 5. But in mine right now, only module 1 has the 3 blocks. Is that how it's supposed to be? Because 2, 3, 4, and 5, I don't have extra questions.
Are you talking about the course or the question bank?
The question bank.
Yes, because I have questions that will be updated, sent out, different ways of showing the same thing. You do not need those questions. The same content that you are looking at is the content that have helped over 4,000 students pass the board. Do not need it. It's just I'm working through them. It's a lot of work to put them out. And what I do not want to do is cause distress because of incongruency. So they'll be released. I can't promise when, but they are there. But you don't need it. What you need is already available. If you think about it, Amy, just going back to your question, should you do the diagnostic test? No, what you should do now is the questions that we sent out that week, the 600 questions for the crash course review. Now,
you know what? I'm sorry to interrupt. That is actually what I meant. So it's the 600 questions in preparation for this weekend.
Yes, the 600 question, not the diagnostic test. Correct.
So I'll pause doing the completion of module 3 and 4 and do the 600 questions.
Yes, in that case, yes, because in that case you can just like preview. It is in fact the crash course review in different questions format. So that way when we're talking about it, it'll be just like, okay, I remember. Not the diagnostic tests. The diagnostic tests are here, the 4 diagnostic tests. You just want to do that after the close to the board time.
Thank you so much.
All righty.
The second question that I had was with the questions for the crash course, I did not save 3 and 4. Is there a way that I can access that, or it's gone?
No, I mean, if you did not save it, we don't have a record of it. But if you submit it, I have a record on my end and I can send it to you.
Yeah, I did submit it. So I put
So
my
you
email
did?
and everything.
Yes. If you
Yeah.
submit it, then I have a record of that, and you can send me an email. Um, Can't promise coming close to the crash course review. I want to do few changes on day one, so I gotta work tonight and tomorrow to get that ready for the Saturday. Uh, but I'll send it to you after. I just can't promise right now. It's a really difficult time answering all the emails, but I will get back to you if you need them later.
It's just, but I was like, I thought I saved it, but only the certificate got saved. So I was
Oh,
hoping
okay, yeah.
to
Just send me an
review.
email. I'll look it up, and then I will definitely send to you again. But again, if you've done it, it's not necessarily that you need it right now. If you've done it, all what is important is when you see the subject, you're gonna be like, "Oh, I seen this. Give me something new. Give me something new." Okay.
What is it called again, please? For the Kahoot, what is it called?
The 600 questions. It is in the same email that you received the Kahoot. It is in the same email for the
Oh no,
event.
I mean for this Kahoot, they kicked me out. I'm wondering what is it called? How did you get?
I'm not entirely sure what is your question. What do you mean? What is
I
called?
mean the code to get into the Kahoot. What is the pin number? Sorry.
The game is done.
The Kahoot is over.
Oh, it's done already.
Yes, that's why I
Oh,
wasn't
wow.
understanding your question.
Okay,
But
sorry for that.
what we're going to do is we're gonna send you the recording. We recorded this, we'll send it to you if you want to watch it. But honestly, guys, once the Kahoot is done, if you've been here, move on because the Kahoot is good if you're in your car and you want to listen on a road trip. Move on. We just got to keep on moving because there is more content coming, right? All right. Next person is Janice.
Hey.
Hi.
All right. I got two questions. During my
Sure.
studying, so I want clarification regarding the inducers. So like let's just say like carbamazepine, it is it's like the chief of all the inducers. Does that mean that it's going to induce any drug that it comes with, or is it just going to induce the metabolism of certain drugs?
Certain drugs,
Okay.
but that one it kind of metabolizes itself. It's that potent. So on the board, if you see carbamazepine, you can almost bet with 100% confidence that is related to inducing something else. And what the board is going to ask you for is increasing the dose of the other medication.
Okay.
So
Is it
before you ask that, let's just go back to the inhibitor. So with that, you need to be watching out for things like Depakote and Lamictal. Well, because if you have Depakote, which will inhibit Lamictal, now you have a possible case of Stevens-Johnson syndrome. I just want to connect those 2 points because they are well tested. The the carbamazepine and the Depakote.
the carbamazepine? Okay. All right. Thank you for that. And
All
then
right.
my second question is, well, last week when we were discussing like the antidepressants and how you were saying the SSRIs, whenever you're gonna stop one drug class and start another one, you wait the 2 weeks unless it was the
Yes.
Prozac. So my question is, when you're stopping that and you gotta wait that 2 weeks before you start another one, what is the patient doing for depression in the midst of that 2 weeks? Are they
Well,
just on nothing?
yeah, no, that's a good question, right? Basically, we're trying to prevent a serotonin syndrome. And if we go way, way back then on the books, right, back in school, basically it's saying, hey, there is still serotonergic agent in the body, and we want to clear that before starting something new. In reality, real life, what I would say is cut the medication in half, and then maybe 1/3, and then start something else on top.
Oh,
Now,
okay.
other providers just may say take 3 days and start something else. What we do not want to do is Prozac. Prozac has a super long half-life, and starting something else on top of Prozac, it could cause serotonergic side effects.
Okay, thank you. I don't think I connected it to the serotonin syndrome, so I might have wrote it wrong and understood it.
No, you understood. It's just that there is still left medication in the body, and we want to clear that before I start something else. In real life, we have a lot more room. It's just that for the board, to keep the theory in one place, we should wait 2 weeks to completely between one medication and another. Basically, in the board, we're trying to be super safe.
Gotcha. Okay, thank you.
Alrighty. Next person is Patricia Morales. You are muted if you're trying to speak, okay? If you want to unmute yourself, let me go with the next person and I'll come back to you. Emmanuel.
Good evening, Dr. Lopez.
Good evening. Hi.
Thank you so much for your good work.
Absolute. Thank you. My pleasure. How can I help you?
I have less than a week to do my test.
I know. I was going to say you about testing soon.
Yeah, and I just finished Diagnostics 4, and I was going through, the whole questions to look at those I didn't do very well. Somehow it disappeared. So I just wish if I can get it so as to be able to finish what I was doing. Secondly, between now and my test date, I have two options: go through diagnosis test 1 to 4, or go through the modules, the PDF. So which one do you suggest I do?
It is a tough question. Well, first you gotta send me an email. I gotta look in your email and then send you the copy. Okay.
Okay.
Now under your course here, we have 4 modules that you really need to know. Specifically the first 3, right? This one is already covered inside of those first 3, but somebody said, hey, can you make one that is only medication and neurotransmitter? I said, okay, no problem. But really, this one is inside here. But you gotta know those really well. But you do have time. You still have time, one day, and you can still go over the diagnostic test. I would redo the diagnostic test that you didn't do so well at the same time as you're trying to go over this 3 PDFs in the crash course review.
Okay.
Okay. Now, when you say you didn't do too well,
No, I did actually. The diagnosis 4, I would say, I don't know, I had 86.2.
So then you shouldn't be concerned about attaining at all. I mean, you should be just kind of like revising this strategically. I love what you did, which is waiting for the crash course review to be done and then testing. We have people testing on the Friday. Well, it's kind of the question is, why didn't you wait until Monday? A lot of people pass today. Maybe they don't need to, right? There is no need to wait. But if you're in the fence between when should you test, aim it for after the crash course review. We'll have another one in February, or the 21st and 22nd. It's not your case. You're already.
I'm long gone by special grace.
Yeah, no. Yeah, no, it's not your case. But like, if you're like in the fence, should I test like next week or 2 weeks from now? If you have a job waiting, or if you have something that you must, then you do. But if you have the opportunity to aim it after the crash course review, often that will yield 10 extra questions or so that you could, potentially miss. But because you just saw the crash course review and you tested after, it makes it a bit easier.
Yeah, I'll be available for the 2 days. Yes. I'll be there. Yes, definitely.
Alrighty, good. Amy, any other question, Manuel?
That's it. Thank you so much.
All right,
well, I'm going to send you an email just in case you can send those back to me. I'll appreciate it.
I'll sure do.
Thank you, sir.
All right, my pleasure. Amy.
Hi, good evening, Dr. Lopez.
Good evening.
I have 2 questions.
Sure.
The question is, so going back to the question about for a schizophrenic patient, who develop akathisia, and the answer was to give beta blockers. But if they have asthma, do we give cogentin or?
So, the problem with beta blockers is that it can cause bronchial constriction. You need to know that, right? So if you need to, then you got to ask why you're giving a beta blocker. What is the condition? Most likely will be someone anxious going through a test or an event, or has anxiety, and the event is causing extra anxiety. So in that case, you need to give an SSRIs. Okay. Yes, because most likely that's what's evolved around that. Because it's presenting a patient that's anxious, maybe having anxiety, going to give a speech or take a test or something, and option A, beta blocker, right? Because it's for anxiety specifically induced by a situation. But in that case, you want to give a SSRI. And why not beta blocker? Because they will say the person is asthmatic or uses an inhaler. May not say asthmatic, may say uses an inhaler, and you have to connect the dot.
Okay.
Dr. Lopez, she was asking if the patient has akathisia and they have asthma, and you can't give the beta blocker, what would we give in that case to control the akathisia?
I mean, you could, what are our options for? We could give Atarax, we could potentially give Buspar, right? So that's more like a real patient scenario. Would work, but what I was trying to cue her in is how the beta blocker will most likely come in play for the test. But in real life, Atarax would work super well because you just want to easy the restless.
Okay.
My second question is, so I'm taking my test in March, but I'm just up to module 3, and we have the crash course this weekend. I feel very pressured to do 600 questions in one day.
No, you don't. I mean, everyone's in a different life cycle, right? Some people joined the course yesterday. It's okay. You can do them after. Okay. Just do them as a way to practice. The questions are not even high yield to a point where they're like, what is high yield as your diagnostic test? The crash course review is a way to preview the content before you see it. You don't feel pressure. You got time. It's not like that you need to keep those, save it, whatever you complete the module 1 or question bank 1 on that for the crash course review, that's fine. 2 or 3. If you can, you can, but don't be up all night studying. Relax. Just make sure you got your coffee, you got your chocolate. It's going to be a long day. Got some snack. It'll be okay. You have plenty time. Okay.
Thank you.
All right. One thing on that portion is, everyone, you should be doing each module 1 per week, right? Because that's week 1, week 2, 3, 4, 5, and 6. Now you have 8 to 10 weeks, ideally, to do and refine your craft. As you move from modules 1 and 2 and you're about to start module 3, take a day to review PDF 1 and 2. You always want to review what you learned rather than just doing things for doing things. As you complete a module, make sure you do the question bank associated with the module. You don't want to watch the videos and move on to the next module without practicing what you learned. As you see, a lot of people did really well today. It is from what we learned last week. So we don't want to just learn. We want to learn and apply it. Okay. Thank you for the question there. Next person. Do you have another question, Amy?
No, thank you so much.
My pleasure. Nancy.
Yes, Dr. Lopez, how are you?
Good, and yourself?
I am not doing well.
Okay, how can we make it a little bit better?
Yeah. My question is about the crash course this weekend.
Okay.
I am not done with the first module.
It's
So
okay.
is it okay to just
Yeah.
be part
Yeah,
of it?
just join us, soak it in what you can soak it in. And then after that, continue on your path of the individual modules. And then we'll start module 2 the following Tuesday. That is completely okay. The crash course, it is an immense event. It's 16 hours live. You know, the more you attend, we're not saying, oh, wait a minute, you can only attend one. That's why we have a lot of students, because I completely say, hey, attend as many classes as you need. So come, you are going to learn a lot. You're going to see new things. And as you complete your modules, that starts to click and seeing the same content over and over again, making impossible or very difficult not to achieve your success. Just come and then attend one in February. If you are with us in March, probably not, you'll probably be done by then. We have another one in March. So we're not prohibiting or saying, oh, you can only attend one class. We don't do that. You can attend as many classes as you want. Okay?
I appreciate it. Yeah, thank you.
My pleasure. All right. The next person is Debbie. Hey, Debbie. If you are trying to speak, you're muted, okay? I'll come back to you in a second then. Mrs. Chai, do you have do not have audio files? Let me see here. Do not have audio files. I have a long drive to work and will appreciate an audio file. What do you mean by that? Okay, for the modules. Okay, Debbie. I don't have an audio files, right? We have an app that you can listen to, but I almost beg you that you don't. If you want to listen to, this is why I pulled this up. You want to listen to module 11. This is 8 hours of one-to-ones that I did with previous students. So when you guys say, well, I finished everything, you know, what can I do now? This is a great opportunity to just listen to the ones-to-ones that I did with previous students. Okay, if you don't want to log in on the app, go to the YouTube channel and listen to the crash course review, the parts of it that we have in there, or to modules 1 or 2 and 3. What you do not want to do, Debbie, in my opinion, is going through a video for the sake of going through the videos as you're driving, because your course is going to mark down as completed. And next time you log in on the computer, it's going to say completed, but have you really completed, or you simply listen to it, right? It could go both ways. And I really want to go in a positive way in which you listen, you understand, you take notes, and then you apply it. So if you want to bypass that, you can download our app and you can listen to on the road. I don't recommend it. But if you say, okay, I still want to listen, absolutely do module 11 or go to our YouTube channel. Okay, that's my recommendation there. I do the course, but I want to repeat what I have done. Yes, you can download the app and you might be able to hear from the app, but I don't have a module like a exclusively an audio file for that yet. Okay. Been thinking about it, but I can't promise you a specifically audio file. I've been looking at some tools just to give you an additional tool, but I don't have that yet. All right. Renee, do you have a question there?
I do. Hi, Dr. Lopez. Thank you for your time.
Yeah.
I'm kind of new to all of this, so I am just trying to navigate everything, but I thought that I read somewhere that you had a PDF that was kind of like a cheat sheet for when you arrive to the exam.
Yes, so there'll be your crash course review.
It's in that. Okay, because I
Yes.
printed everything out, but I hadn't gone through everything yet. Okay, so I'll find it in there. And then this second question I had, when I finished module 2 and did the test, it felt like a lot of the questions were
Yes.
not covered. So I'm doing the right test. That's how it is. Okay.
Yeah, it is hard to talk about medications and not mix it with therapy. So some
Okay.
of this will play out on module 3. Go with the flow of learning as you go, but you are right. They are not necessarily 100%. They might be like 15% or 10% off of what wasn't covered. And the other reason for that is to either learn ahead and most likely, for example, on module 1, I have one question there that talks about escitalopram. What do I care about escitalopram? The only one thing that I care is QT prolongation. So I'm not going to do a lecture about one specific thing. So then I'll create a question that covers the intent.
Okay. Okay. I
But
got
yes,
it.
module question bank module 2 is a little bit off because it covers a lot of things on module 3. Some things bleeds into the other modules a little bit, but just read the rationale, and then as you see it again on the next module, you can kind of, oh, I remember that. Another thing is you can always go back and redo the question bank as you please. You can do it as many times as you want if feels necessary at some point.
Okay. And the questions on those banks, are those like lower level questions, or are they ones you
They
might
are
actually see? Because some of them felt
basic, huh?
Slightly. I did
Yeah.
surprisingly well, and I thought, okay, but I'm not trying to get overconfident. I know there's a
Yeah.
lot of stuff I'm missing.
Yeah, I mean, the theory behind it is what you're going to apply it. So, questions might be such as, if you have a patient on lithium and you listen to his heart and you hear a murmur, what kind of questions would you ask this patient? Well, lithium causes heart defect. And now you have to connect such as, did your mother
Parent
take
use.
lithium? Basically, I'm covering several factors here. 1, do you understand the content? 2, that bipolar family is probably the number one um, uh, thing that you would look out for in bipolar, right? It passes through the family. So it's a lot of applications. So it might be a little bit at times dumbed down or smaller content, but that will serve you well on the test.
Okay.
Because you will remember to connect the dots. So basically, I'm giving you 80% and then you'll be able to complete the 30, 80, 30, 20% left. Now, I uploaded this video here recently under the homepage, and this really walks through, maybe you already listened to this or not, it's
Yes.
under the homepage. So it really walks through like what is expected or how other students before you did so well. And if you watch that video, it explains a lot of things. But thank you for your questions. Very, very important what you ask for sure.
Okay, I appreciate your time. Thank you.
My pleasure. I know Mrs. Chi was here, but she's gone. Let's go with Dr. Lisa. Hi. Lisa, are you there? You might be muted, but I can't hear you, okay? If you can't speak for whatever reason, you can write it here. But you are muted at this point. Okay. While she's, I don't know why because it doesn't look like you are muted. So, but I'm not sure. I can't hear you anything. Can anyone hear her? No, Lisa, Dr. Lisa, I'm not hearing you at all.
I can't hear.
Yeah. Hi.
Hi, how are you? I was just
Good. Okay.
Are you hearing me?
Yes. 1 second, please. Go ahead, Lisa.
Okay, so Dr. Lopez, I came off the Kahoots and then I came back because I wanted to ask you this question. I heard one of the students just asked about the 600 question that we were sent.
Yeah.
And do we need to send you when we complete each of them?
No. It is for your own learning and the experience. It's more of a review of the crash course. I get every time you submit it, I get it on my back end, so I know who did and who didn't. But it's not necessarily an assignment. It's more like if you feel like that you have the time, do it. It would be helpful. If you don't, it's okay. You can do another time.
How do we submit it? Because I always print the certificate, but I never know.
Well, if you got the certificate, that means you submitted.
Oh, okay. Okay. That's what I came back to ask.
No problem. Thanks for the question, though.
Okay, thanks.
All right. Silvestre Aquina?
Yes, hi.
Hi.
I was just saying that I could hear you. I was just responding to your question when you were asking.
Okay. All right. Anybody has questions about the course, where things are located, or any questions at all? Thank you. Have a good night. Thank you, Faye. All right. So if no questions, then this is the end of today's event. Be ready for Saturday because it's going to be a long day. Make sure you hydrate, get your coffee, and I am super stoked that that you are in this course, and I really do not want to lose anybody through this preparation. So stay steady. It is more important than how long you're in the course is your intensity, right? You learn something on module 1, guess what? If you don't revise it for 2-3 weeks, your memory probably 30-40% of that's gone. But if you take it 40 minutes on a Monday and always review module 1 PDF, it should not be more than an hour and a half, because now you're not listening to a video. You're not waiting for me to pause. You're simply going through the content. And when you do that, it's the best way is not to read the content, but just look at the topic, lithium. Okay, what are the things I remember about lithium? What are the contraindications? What are the medication will cause lithium levels to increase? And try to speak about it, because that way it builds confidence. And the more you can speak without seeing the content, there is nothing else but knowledge. You got this, okay? With that being said, everyone have a great night. See you guys Saturday. Let's go ahead and pass this test, each one of you guys. Good night, everyone. All right, we got one more question here. Hey, Olu BP. Hi.
Hi, I was just trying to make a suggestion regarding
Please.
good evening. Trying to make a suggestion regarding, because I'm like I have like, I don't know, I think I emailed you about it, about extreme ADHD. So when I just started the course like 2-3 weeks ago. And so when I see the modules, like module 1, it's like 23 videos. I'm like, I'm not gonna finish this. So that was just what I thought. That's a lot for me. So I'm used to like, maybe if just a suggestion, if you have like the audio, somebody said an audio, but if you have like the module 1, just one video, maybe it's 2 hours, and if somebody's driving, they're gonna listen to it. Like then module 2 to maybe 2 hours. Like if you can combine all the videos together in one, for me, I think that would be easier to go through than clicking on it, because a lot of time, like I'm a mom, I'm driving all the time everywhere. And I had to like, okay, let me play the next video, because I'm I'm driving and I'm trying to get my phone to play the next, because it's very short. It's good for some people. Some others, if you could put it together as a one video, like module 1, just one video, module 2, just one video, like that would be good, because I know you have that on your YouTube page as well.
Yeah, but let's think about that for a second. If you cannot maintain, a person with ADHD, they cannot maintain 10 minutes of concentration, how would they be able to do that in 5 hours? So the idea is that you can do little pieces at a time rather than doing everything and rushing. Now, if you prefer to do that, we have an option, module 12, right? So if we click on module 12, what is it? It's the live reviews. And now they are going to be 3 hours long.
Oh, I didn't even know that you had module
Yeah.
12. I didn't go
Yeah.
to module 12 yet.
I mean,
Oh,
but
okay.
honestly, that's not going to work well for you, because if your goal is to actually learn and keep the information, you do not want the 3 hours lecture. You really want to focus on as much as you can for 30 minutes and move on. Next day, you pick it up again. Because if you open this video and it's 4 hours long, 3 hours long, you are going to go through the content, yet you're not going to retain it as much. Think of this way. If you watch a movie, you always remember the beginning and the end, and then the middle is always fuzzy, right? So if we break it down the movie into smaller pieces, you are going to remember much more. You know, that is the way ADHD folks work, and this is why we do micro learning. Small pieces, focus, gone. Don't stay there all day. You know, take 1 hour a day and do it with intensity and purpose rather than watching it for the own ego of saying, I'm studying, I'm sitting down, right? It's all about intensity and purpose rather than checkbox. Oh, I got it, right? Because anyways, it's a suggestion, but we have that available on module 12. That is your live classes. Then you can kind of like go through that if you prefer it that way. I don't think it works best, but something you can try and see it for yourself. It is just a different way of showing the same content, but now we have people jumping in, asking questions, which can be more distractful for somebody that already has a lower attention span. But it's there. So we try to provide different ways of doing different things. You know, so that way one thing didn't work, maybe something else will.
Yeah, the reason why I said that was because most of the time I'm always driving, and so I have to like pause to play the next video. But if you have like an audio, like somebody said, an audio or a long video,
but
then
you are trying to compensate for the lack of a time, which will lead to most likely a negative outcome because you are listening to it, but you are not retaining. Especially if you have a short attention span and you're driving, you're listening, great. But that is not recommended for study, right? You were trying to, I'm not saying you, I'm saying, you know, we're trying to overdo because we're not having enough time. So what I suggest is taking a little bit longer in the course, but doing with purpose and intensity. But again, is that module 12, you can try it. If that is what you think it works best for you, you can give it a shot. Okay.
Thank you.
Yeah, my pleasure. All right, folks, nobody else has any other question? If not, that is good night, goodbye, and good night for tonight. I'll see you guys Saturday, 10 a.m. Eastern Standard Time. See you guys soon.
Thank you.
Thank you. Bye-bye.
Thank you, Dr. Lopez.
Thank you. My pleasure. Bye. Good night.